Hello everyone, this is Dr. Saroj Siddharthi from the platform of UKMLA with DSS, and let's just continue the psychiatric cases that we were studying in the success course of the UKMLA 2 exam. Okay, so the next case that we are going to do today is basically the psychosis case, also known as the schizophrenia case. Okay, and it's a very famous case because it kind of get difficult. Okay, because the patient in this case does not open up, and it becomes really really difficult for you to make sure that the patient is comfortable, make sure that the patient is willing to listen to you and willing to understand what you're trying to say. Other than that, mostly the patients of schizophrenia or the patients who are undergoing psychosis, they do not have the insight that something is wrong with them. So insight basically means that, first of all, accepting and understanding that there may be something that is going wrong with their body, with their mind, and most of them, they don't have the insight, and that is why it gets a bit difficult to do the data gathering. It's a bit difficult to make sure that the patient open up and talk to you about the concern, because number one, he or she doesn't think that this is a concern at the very first place. Okay, so it's a pretty challenging session, and you may have to take a lot of data, and you will have a very less time, and there would be a time crunch involved. Okay, so you need to put all your steps right. Okay, and make sure that you are asking the right questions, the relevant questions, in the right way, in the right order, because there is very little margin of error with such a time crunch involved, with so much complexities with the patient's behavior. Identifying the non-verbal clues, and non-verbal clues would be typically there. The typical non-verbal clues there would be there in this station. So you would have to make sure that the patient is comfortable, the environment is comfortable. You are acting in a very friendly and a supportive way to the patient. So there is a lot to do in this station, and there's a lot to manage, and there's a lot going on. Okay, so let's just discuss that what you need to do whenever you receive a case like this. So first of all, I'll just share the examples. There may be a case where the patient would be going to a police station to get himself arrested. Okay, and then there's another famous case in which the patient believes that he is King Charles, or the patient believes that he's chased by a detective, or the patient believes that King Charles is usually chasing him and calling him, and King Charles wants to talk to him. Okay, so there are different presentation of this case. There are different scenarios in which the psychosis case and the schizophrenia case presents. Okay, so the first and the foremost thing, after doing the introduction and after doing the rapport building, okay, you need to identify the non-verbal clues. Okay, you need to identify the non-verbal clues. You need to acknowledge them. You need to validate them. You need to create a safe environment, offer a safe space, offer confidentiality, and once all of it is done, then only the patient would start opening up that, yes doctor, I am having some issues. Yes doctor, somebody is chasing me. Yeah doctor, somebody is asking me to do something. Yeah doctor, there is some person who constantly keeps on coming in front of my eyes. Yeah doctor, there is someone at my home that often keeps me commanding and ordering me to do things that I don't want to do. Okay, so that means that this patient is having hallucinations. Okay, before I go into the details of hallucinations, there are three things that I would like to mark for you, and that is like very important. And since we are at the beginning of the psychiatry section, you need to understand what a psychiatric specific history is. Okay, so in every psychiatry case, in every psychiatry case, okay, you need to develop a habit of asking three different questions. Okay, what are the three questions? Number one, you have to explore about the hallucinations. That by any chance do you see or hear things that are not usually present? Okay, then you need to ask about the mood. That, can you please rate your mood on a scale of 1 to 10 for me? And then you explore the harm. That, do you ever feel the need to harm yourself? Okay, so these are the three questions that definitely needs to be there in all the psychiatry sessions. This is what we call as the psych specific history. Okay, and in the psychiatry station, either the issues would be with the hallucinations, would be with the mood, would be with the thought of self-harming, okay, or it may be a completely different psychiatric issue, but nevertheless you would have to explore all these three categories. These three categories needs to be explored in all the psychiatry cases that I'm going to cover. And how you're going to verbalize it, that by any chance do you see or hear something that is not normally present, that others don't see, okay, and then how would you explore the mood, that can you please rate your mood on a scale of 1 to 10 for me. And then about the harm, do you ever have the thought of harming your own self or harming someone else, okay. These three questions are like really really important in every psychiatry case, okay. So I'm going to cover all of the psychiatric cases, and I'll see that, and I'll show you that how all these three categories are incorporated. Okay, but since we're doing a schizophrenia right now or psychosis right now, let's just follow the structure and follow the approach that we need to have for this particular station. Okay, so the first thing is exploring hallucinations. Okay, because that is what the common presenting complaint of the patient would be in a psychiatric in a psychosis station, in a schizophrenia station. Okay, so the patient would be saying that, doctor, I see something, I hear a person talking to me, there are some detectives who are following me. Okay, so try to be very supportive. Okay, and instead of asking question like this, that for example, does someone say something to you, or do you see someone, okay, instead of saying this, try to use what the patient said. Let's suppose that the patient says this, yeah doctor, there is a detective that keeps on following me, he's also at the back right now. So try to use that scenario, that okay, Mr. Frank, I can understand that you are seeing someone who is standing at your back. Does that person say something to you? How often do you see that particular detective? How often do you see King Charles? How often do these people ask you to go to the police station and get yourself arrested? Where exactly do you see this particular person that is there on your back? Okay, so what kind of difference would it create? Because in the outside world, this patient, like nobody is accepting this thing because it's an hallucination. That is something he's saying, okay, and the world is calling him mad, and the world is calling him and saying that, okay, there is no one there, you're just mad, you're just acting like a weirdo, you're just being stupid. Okay, but as a doctor and as a healthcare professional, as I told you, that you need to create a comfortable environment for him. Okay, so try to relate and try to pick up those things that the patient is saying. Okay, so if you ask this question using the reference to the kind of hallucination this person is having, he or she will be more comfortable in talking to you and opening up to you. And because they would understand that, okay, at least this doctor is acknowledging the fact that I'm seeing something. At least he's not just asking the questions just for the sake of asking. At least he's able to relate to me. Okay, so always try to use these hallucinations. Okay, even if the patient is not opening up, even the patient is getting you know very in a panicky situation, try to use these things. Like for example, sometimes the patient would be so much in distress, so much in anxiety, that they would not let you explore the hallucinations at all. Okay, so what you can do is that you can say this thing, that okay, Mr. Frank, if you are able to answer a few questions for me, I am going to assure and I'm going to try my best to make sure that the person that is bothering you, or that the people that are bothering you, or the people that you are seeing, or the people that you are constantly hearing, I'll try to get them off your back. I'll try to keep you in a safe space. I'm going to make sure that these people which you are seeing at your back right now, or these people which you are constantly hearing right now, they don't disturb you. I'm going to get them off your back. If you are just able to answer a few questions for me and tell me what these people are doing, what these people are saying, where do you see these particular people, or where do you see this particular detective, where do you see King Charles, okay, who tells you to be or act like King Charles. Okay, so try to use that particular scenario, try to use the hallucinations, try to use the symptom and the condition that the patient is facing to make sure that the patient gets comfortable and patient opens up and patient is much more willing to answer your questions. Okay, otherwise if you just keep on asking what do they do, who do you see, if you just keep on asking it directly, then it's unlikely that the patient would get comfortable. Try to use this, use your body language. The person that you're seeing at the back, can you please tell me what he does, what he says? All right, try to use the entire room, the entire situation for your benefit. Okay, so this is how you're going to explore the hallucination. This is what is the art of exploring the hallucinations. Okay, so once you're done with that, the next part of hallucination is exploring the thought. Okay, now the thought, in Plat 1 you must have studied that there is thought insertion, thought deletion, thought broadcasting. Okay, so you just have to explore it in a very subtle way, and you have to ask that instead of saying that does someone enter some idea in your brain, say that does this person, does King Charles, does those police officers, they try to enter some ideas in your brain. Okay, or do they take away some ideas from your brain? Does that police officer, does that detective take some idea away from your brain or from your mind? Okay, and do you often think that whatever you are thinking is read out loud by these detectives, by King Charles, by the police officer that is constantly chasing you? Okay, try to use this thing and try to explore the thought, whether or not there is thought insertion, thought deletion, or thought broadcasting that person is facing. Okay, so hallucinations and thought is the like most important two things in a schizophrenia station that you need to inquire, that you need to explore. All right, after you're done with that, okay, then after this, like till this stage, you have addressed the non-verbal clues, you have validated his feeling, you have offered a safe space, you have offered confidentiality, and then while exploring hallucinations and thought, you were trying to relate to the patient. So till now the patient would become very comfortable. Okay, the patient should become comfortable in talking to you and asking his concerns to you. Okay, so now you can just ask about the direct questions, like can you please rate your mood on a scale of 1 to 10 for me, with 1 being the lowest and 10 being a good mood. Okay, and then they're going to say, yeah doctor, my mood is a 5 on 10, 6 on 10, 4 on 10, 3 on 10. Okay, they're just going to give you a number. Okay, so you explore the mood, and then the next psychiatric aspect, that is exploring the harm. Okay, by any chance do you carry a weapon? Often the patient who are having hallucinations, they're so scared of the hallucinations and the person that they're seeing, or the thought that they're constantly getting in their mind, they often carry a weapon, that okay, whenever next time this person or that hallucination comes in forward, comes in front of me, and is going to shoot that particular patient person. Okay, so they often carry a weapon. So you need to ask it, by any chance do you carry any weapon for your self protection? Okay, and then they also have suicidal tendencies. So you gotta ask that, okay, do you ever had a thought of harming your own self? Okay, or does that particular voice, or does any voice ask you to harm your own self or someone around you? Okay, these are the three aspects that you need to assess in detail. That, okay, do they carry a weapon, number one? Do they have suicidal tendencies, number two? And number three, is the hallucination or is the voice that they're hearing asking them or directing them to either kill someone or to kill themselves only? All right, so these are the three questions, very important questions that you need to ask when you are assessing the harm. Okay, so hallucinations and thought is basically a subcategory of hallucinations. Okay, so hallucination number one, then mood, and then the thought of self harm. Okay, these are the three major psychiatric aspects that is covered in this station as well, and that is going to be covered in all the stations. Okay, so you need to keep in mind these three particular categories and these three questions. Okay, so yeah, so this was the first four layers of schizophrenia case. Now the next layer is DESA. Okay, we know what DESA is, but I'll just do some additions to it. Number one, in the DESA, the diet may not be important. Okay, so what I have done is that I have modified DESA a bit, and then I've added the drug aspect to it. Okay, so why is it important? Because somebody, if they are IV drug abusers, okay, if they are taking recreational drugs, then they may see hallucinations, they may have hallucinations, okay, they may have a low mood, they may have suicidal tendencies. So it may not be schizophrenia, okay, it may be a drug induced effect, okay, so you never know. All right, so you just have to, inquire about that. That by any chance, Mr. Frank, it's a bit personal question, but it's better for my understanding, and I'll be able to understand your condition in a much better way. By any chance, do you do any recreational drugs? Okay, just one question. Okay, then exercise and smoking may not be important. Smoking, yes, if somebody is smoking weed, then it may be important, but that aspect would be, covered in the drugs part when you ask about the recreational drugs. Okay, then alcohol. Okay, can you please tell me by any chance, do you take any alcohol? Why? Because there is alcoholic hallucinations that are like very very common. People who are chronic drinkers, they do develop the habit of, having alcoholic hallucinations. Okay, so you need to rule out the possibilities of drug-induced hallucinations and alcohol-induced hallucinations. All right, so important category, important aspect. The next aspect that you need to do is basically the meftosa. Okay, and there are a few important aspects of meftosa that you need to cover. Number one, by any chance are you taking any medication? Okay, so certain psychiatric medication or certain neurological medication do have these effect that it causes patient to hallucinate. Okay, then you just ask about the past medical history, if they have any Alzheimer's, if they had any neurological conditions like Parkinson's. Okay, so just talk briefly talk about that. Family history, like schizophrenia, psychosis, and all the psychiatric condition, they are very 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 much related to the family history. Okay, then occupation and driving in the psychosocial aspect, very important. Somebody is schizophrenic, they are having hallucinations. You need to understand that whether or not they drive, whether or not what kind of work do they do. Are they working on dangerous positions? Like, are they working at heights? Are they working as a healthcare professional dealing with the lives of the patient? Okay, so they can be risk to a lot of people and to themselves as well. Okay, so you need to ask about the occupation and about the driving as well. Okay, then the social, the psychosocial aspect. Okay, in the social history, it's important to ask about who is at home, do they have friends and family members available, because these patients, psychiatric patients, they are already going through a lot mentally, and they do need some kind of support and some kind of uh, like a moral support basically. They need that. So you need to ask if they are alone at home, if they have friends and family available, because if they're completely alone, if they don't have friends, if they don't have family, then the chances and the risk of them developing schizophrenia and them having hallucination is way more as compared to someone who have friends and family member available, as compared to someone who is not living alone. Okay, so all of these questions become particularly important when it comes to the data gathering and the history taking of a schizophrenia case. Okay, so yeah, so there were total six different aspects that I talked about: hallucinations, thought, mood, harm, the drug part and the alcohol part and data, and a few aspects of the meftosa. Okay, so this is pretty much it for the structure part. Okay, I hope that it's written down in your notes. You've very well understood it, and you know that okay how the case would present and how to make sure that you're asking the questions in the right way. Now, there are a few important things in the psychiatry station that I want to discuss and I want to talk about specifically in the schizophrenia case. Okay, and I'll discuss all of it one by one with you. Okay, number one, how to explain the diagnosis. Okay, so a lot of people, they end up just saying that you have got a mental illness. That okay, thank you, Mr. Frank, for answering all my questions uh, from the chat that we have had and from my examination finding. You may be having a mental illness. Okay, do not say that. I'm not a very big fan of using the terminology of mental illness. Like, just think about it. The world is calling him mad. Okay, the world is calling him a weirdo. The world is calling him stupid. Okay, and he's here for his support. He's here for some assistance, some help. And at the end of the day, we as healthcare professionals are also calling it as a mental illness. Okay, it will offend the patient. Okay, it will make the patient uncomfortable, and they're just gonna get the impression that okay, the world is calling me mad, and so does the doctor. Then that means I'm actually mad. Okay, that would further lower down his confidence. It would further have a negative impact on his mental health. Okay, so you do not say a mental illness. Do not use this word. Okay, instead of it, what you can say that okay, Mr. Frank, thank you so much for answering all my questions from the chat that we have had and from my examination findings. You may be having a condition of your mind. Okay, we are saying condition of the mind. Okay, we're not saying mental illness, and do not say condition of the brain. Condition of the brain is basically neurological condition. Okay, psychiatry is basically dealing with the mind, and there's a difference between mind and the brain. Okay, so from the chat that we have had, you may be having a condition of your mind, okay, in which the patient may experience a false perception of reality. Okay, in very easy terms, you've just explained hallucination, a false perceptions of the reality. Okay, so this is the pathology. Okay, the organ is the mind, the pathology is the false perception of reality. Okay, and it is a pretty manageable condition, and we call it as psychosis or schizophrenia. Okay, so the basics is there, the same basic is there. Okay, that I taught in the earlier lecture. It's just that you shouldn't be using the word mental illness. Okay, it's not right to use the terminology mental illness. Okay, so that is how you're going to explain the diagnosis. If you end up saying mental illness, then even if you've diagnosed the schizophrenia case, you may not be getting a mark for the diagnosis. Okay, very important. Then a lot of people are like confused, and a lot of students are like really confused on when to actually admit the patient. Okay, so there is a criteria. All right, remember we asked about the mood, we asked about the self harm. Okay, so like it's very important that you pay close attention to these two things. Okay, what are these two things? Number one, mood. If you find that there is the mood that is less than equal to 4, okay, in the psychiatry case or in like in any case, okay, in not just psychiatry cases but the cases of chronic diseases as well. Okay, somebody, if they have a chronic disease and you just ask about how has it affected your life and how is your mood on a scale of 1 to 10, and if they say that their mood is 4 or less than 4, okay, then you have to admit the patient. Okay, so all psychiatric patients having a mood less than 4, they need to be admitted. Why they need to be admitted? Because a mood less than 4, that it means that they are having a severe psychiatric issue. They may have a tendency of self harm, they may end up doing something to themselves. Okay, so whenever you find a mood less than 4, always offer admission. Okay, number one. Number two, if they have a risk of self harm, or if they have attempted self harm, okay, or they've attempted suicide, okay, then you have to admit the patient. Okay, then you definitely have to admit the patient. Okay, second criteria. Third criteria, if the patient is harming others' life. Okay, let's suppose a schizophrenia patient, he may not have thought of harming himself, but he may be carrying a weapon and he's saying that, doctor, next time whenever I see the detective, I'm going to shoot him in the head. Maybe he may end up shooting someone else, okay, because of his hallucinations. So he is a threat to the other people's life. Okay, and there can be a danger to other people's life and the people around him. Okay, so you gotta admit this patient. Okay, and as I mentioned in one of my previous lectures as well, do not send this patient to the hospital on their own. Always arrange a transport for them. Okay, so remember these three criteria: mood less than 4, thoughts of self harm, and risk of harming anyone else. You gotta admit. Okay, now, admitting it in art, what does that mean? Okay, so as I mentioned earlier on in the schizophrenia station, that these people, they do not have the insight. Okay, and there is a very strong possibility that they would not agree to get themselves admitted. Okay, they will say, no, doctor, I don't want to get admitted. I don't want to get admitted. I just want to go and get myself arrested in the police station. I just want to go to the temple of King Charles and go. I just want to meet him. No, doctor, I just want to go to my father, where these detectives are asking me to go. Okay, so they would be more inclined towards following what their hallucination is saying instead of what you are saying. Okay, and it can get really difficult to make them agree to get admitted and make them agree to listen to your advice of seeking medical help. Okay, but there is a smart way to go about it. Okay, like, and I talked about it in earlier on when I was trying to explore the hallucinations as well. Okay, that I understand that you're being bothered by the detectives. Okay, and I understand that you're bothered by the police officers that have been following you everywhere. How about I admit you in our care to make sure that you're in a safe environment and they do not bother you over here. Okay, the people that you are seeing, the people that you are hearing, okay, I understand that they're everywhere. Okay, they're present everywhere. Okay, you'll go outside, you're gonna see them. You're sitting over here, I know that you're seeing them. Okay, you'll go to your office, you go to your workplace, you're gonna see them. But I want to reassure you one thing, that if you get admitted in our care, I'm going to make sure that you're placed in such a ward which is safe, which is secure. No one else is allowed in this ward except you and the medical team. And this way, you're going to make sure that the people that are following you gets off your back. They don't bother you over there. They don't disturb your mental peace over there. They don't come and keep on instructing things to you that you don't want to do. If you get admitted, and I'm going to shift you to a very safe place. How does that sound to you, Mr. Frank? Or if they think that, "Oh, I want to go to the police station, I want to get arrested," then you can use this scenario that, okay, no problem. I do respect your wish that you want to get arrested. You want to go and visit the police station. How about we keep you here for a while, and once we make sure that everything is all right with you, then we can take you to the police station. Will that be okay? At least give him that, some hope that, all right, like, this is a two-way thing, and the doctor is not just imposing, okay, what he or she wants to impose. Okay, the doctor is considering my demands as well, my concerns as well. Okay, so very, very important to be smart. Okay, be very diplomatic, and this is something that you will learn, as much as you practice and as much as you get involved in the PLAB 2 or the UKMLA 2 preparation, you'll learn this thing. Okay, all right. Let's suppose that even after you have used the smart way that is taught in the DSS course, even then the patient is not agreeing to get admitted. Okay, and the patient is fulfilling this particular criteria of getting admitted. Then what you need to do is that you need to at least verbalize that, okay, Mr. Frank, I understand that you don't want to get admitted, but since your condition is a bit serious. Okay, I would still like to admit you using the Mental Health Act 2010. You don't need to say 2010, but you just need to say that I'm going to admit you using the Mental Health Act. Okay, and it is basically the act that is in the NHS, which is basically made for individuals with mental health illness and mental health condition, that helps a doctor admit the patient or keep the patient in their care if it is necessary for the safety purpose, for their own safety, or for the protection of others, and for the protection of life of others. Okay, so if nothing works out, okay, if the patient is not agreeing to you at any rate, okay, then use the Mental Health Act. Okay, so this is what your trump card is. Okay, in the very end. All right, you may not just get the mark for using Mental Health Act, but if you haven't followed this convincing. Okay, if you haven't tried to counsel the patient about admission, and you haven't tried your best to make sure that you admit the patient without the Mental Health Act. Okay, and if you have done all of that, like in a very, very nice way, then the Health Act would come into play, and then you would use the Mental Health Act that, okay, fine, the patient is not agreeing to get admitted, what can I do? Let's just use my trump card, and let's just admit the patient using the Mental Health. Okay, so yeah, this was what the important basics were that I wanted to teach and that I wanted to talk about. Okay, remember them. Remember the psych specific history. Okay, like what are the three most important thing in a psychiatric case? Hallucinations, mood, and harm. Okay, and remember the structure. Remember how to display yourself as a supportive healthcare provider, as a person who try to understand what the patient is going through, and how to use this entire situation, and how to very smartly use this entire scenario. Not to just do the data gathering. I told you how you can use the situation smartly to do the data gathering, but also use it very smartly to admit the patient as well. Okay, so this is something that I can only teach. This is something that I can only share with you. This is something I can only tell you. But it's not something that would just come to you with just listening to my lecture. You need to understand this, and then you need to apply it in your practice. Okay, whenever you are practicing it with a partner, whenever you are practicing it with anyone else. Okay, you need to apply these tactics. Okay, until unless you don't verbalize it yourself, until unless you don't say it yourself, you wouldn't be able to do it as confidently as I am doing. The reason why I am able to do it, because I gave my PLAB attempt. I studied it like multiple times. Then I've been teaching PLAB for like more than a year now. I've been doing it with multiple candidates, hundreds of candidates with whom I have done this. So that is how it comes out from me so naturally, so confidently, and so diplomatically, and so smartly. Okay, so you should get an idea that what amount of practice do you need to master this skill. Okay, and how you have to do it. Okay, so that is completely on you. That is where BSS cannot help you. Okay, that is on you. But I hope that the first step of going forward in it is that you should know what you need to do, and then you can apply it in your practice, apply it in your studies. So now apply this. Okay, and if you've got any queries and any confusion regarding the schizophrenia or the psychosis case, then drop them your queries here in the comment box. Reach out to us on our social media, and if you want to have a personalized mock, then scan the QR code and sign up using the details that I mentioned on the website. Okay, so that's pretty much it for my side for today's lecture. Let's meet in the next psychiatry lecture.